Good morning all. So today we will discuss a part of the antibiotics, broad spectrum antibiotics. Okay. So first, already you have read about the sulfonamides, and now we will go to the other antibiotics. First you have to understand what is the meaning of broad spectrum and narrow spectrum antibiotics. What do you mean? So firstly, previously in most of the cases we are using broad spectrum antibiotics. Broad means that can kill or that can become bacteriostatic over a wide range of bacteria as well as other types of the atypical bacteria also. That is both gram positive and gram negative, cocci, bacilli and different other organisms. And narrow spectrum means when our antibiotic is targeted towards a specific type of bacteria. For example, it can act only on the gram positive bacteria or gram positive rods or gram positive cocci or gram negative cocci, like that. There are some advantages and disadvantages of broad spectrum as well as the narrow spectrum antibiotics. For the broad spectrum antibiotics, if we are not sure about the specific type of the infection, for example, when there is overwhelming some infection is happening, where there is mix of the gram positive and gram negative organisms may be there, we can use presumptively the broad spectrum antibiotics. And after that, when we can pinpoint that what is the positive organism of that disease or that septicemia by testing the different types of the samples like blood culture, then we can change it to narrow spectrum antibiotics. But due to the use of these broad spectrum antibiotics repeated times for a long period of the time, most of the bacteria becomes resistant to broad spectrum antibiotic. So if we are using more of narrow spectrum antibiotics, the chance of emergence of the resistance is less. So always remember, if we are using broad spectrum antibiotics, there is more chance of emergence of resistance, bacterial resistance. And another thing is, you know that there are good bacteria, commensal bacteria in our guts. When we are using broad spectrum antibiotics, there is more chances of killing those good bacteria, that bacteria that is needed for our body. So there is some pros and cons of broad spectrum and narrow spectrum antibiotics. So within this broad spectrum antibiotics, the most common and the most commonly used are the two groups of the drugs. One is the Tetracycline group and that is the Chloramphenicol group. Of this, previously these two groups are very indiscriminately used, but as I have already said, that due to the continuous usage of the broad spectrum antibiotics, since they are killing different bacteria, some bacteria are exposed to that broad spectrum antibiotics, but they are not killed, they become bacteriostatic. So over the period of the time, there will be genetic change and more emergence of the resistance have developed. So they are used less nowadays, but there are some newer broad spectrum antibiotics are also emerges that have been shown to be beneficial on a wide range of bacteria. So let's just start with the Tetracycline group. So Tetracycline, which is basically obtained from the soil Actinomycetes. So Actinomycetes is an organism which was systemically screened in the 1940s, and then first in 1948 the first chemical compound chlortetracycline was invented, and then oxatetracycline came, and then different other congeners of the tetracycline came. Now they are just changing some side chains to the tetracycline molecule have been developed. One of these example is the Tetracycline. So you can see tetracycline is present in the soil. In soil there is tetracycline. So we can extract this, we can screen this, and accordingly different chemical compounds will be developed. So broad spectrum, already I have given you a nutshell about the difference between a broad spectrum and narrow spectrum antibiotics. So they are contrasted to the existing streptomycin was available. Penicillin and streptomycin, both of these are narrow spectrum antibiotics. So at that time in the 1940s, 50s, when we are using this, so there are different types of the infections where we cannot speculatively distinguish between whether this is caused by a gram positive or gram negative organism, and then these tetracyclines or other broad spectrum antibiotics came, which we can use and the patient can be healed up. So then the term first broad spectrum antibiotics come. They have wide spectrum activity like on gram-positive cocci, gram-positive bacilli, including anaerobes, that is both the aerobes and anaerobes. Anaerobic organism example is the Clostridia. Gram-negative bacilli, including anaerobes like Vibrio cholerae, Haemophilus Helicobacter pylori, Brucella, spirochetes like Treponema pallidum, Rickettsia and Chlamydia, Entamoeba histolytic and Plasmodia. That is, these are the protozoa. That is, some have some anti-protozoal actions also, and they are orally effective. So, if you are asked what is the difference between broad spectrum or narrow spectrum antibiotics, or why these antibiotics are called broad spectrum antibiotics, so all this to be told. So now coming to there are some changes in the side chains in different compounds. Hydrocarbons, 4 hydrocarbon actinomycetes classified naturally like tetracycline, chlorotetracycline, oxytetracycline, demiclocycline, and synthetic like doxycycline, minocycline, tetracycline, and some like limecycline, metacycline, Raleigh tetracycline, etc. These light blue colors are not available now because of their toxicities, but the other compounds are available. So again, we can classify this as duration of actions, like short acting are tetracycline and oxytetracycline, where the T-up is 6 to 10 hours. Then intermediate acting is the demiclocycline and limecycline, where the half-life is 12 to 13 hours. And long acting is the doxycycline and minocycline, half-life is the 18 to 20 hours. So we can classify, so these are the different examples of the tetracyclines. If you are asked what is the tetracycline, what is the source of the tetracycline, and why these are all comes under the tetracycline, all these are clear, and this is the name of the different tetracycline antibiotics. So available drugs, tetracycline, oxytetracycline and demiclocycline, these are the older ones of lower potency, 250 to 500 milligram thrice daily dosing are usually needed. Orally acting, partially excreted through the kidney. So, and these newer ones like minocycline, doxycycline and the tetracycline, they have higher potencies of 100 to 200 milligram. Lipid acting, we have already increased in comparison to the previous ones, completely absorbed from the stomach and excreted through the liver. So there is difference of the excretion in the older tetracyclines and the newer ones. So newer ones are mainly excreted through the liver. That's why they can be used in the chronic kidney disease. So if the kidney is already compromised, so we can use these ones but not these ones. Tetracycline, now coming to the mechanism of action. So all these tetracyclines and different other antibiotics are there, which mainly acts on the protein synthesis mechanism. So this protein synthesis parts you have already read in the biochemistry, you can revise that. So there are different stages of the protein synthesis in the bacteria, and the different antibiotics basically acts to prevent the different staging. For example, the tetracyclines are primary bacterial protein synthesis by binding to 30 ribosomal subunits. So there are 50S and 30S, 2 ribosomal subunits are there. They bind with the 30S ribosomal subunit, and ultimately the amino acyl tRNA to mRNA ribosome complex that is a part of the transduction is interfered. So the peptide chain fails to grow. So ultimately the picture is also there, I think. Yes, this picture. So you can see this is the picture of the, already you have read this in the biochemistry. So how the transduction, protein synthesis happens in the bacteria. So you will Erythromycin, you read that. So these all are acts at the different stages of the protein synthesis. We will talk about the tetracycline chloramphenicol. So you can see takes a newer peptide, this attaches this, and ultimately transfer of this new peptide code changes from the peptidal ring to the peptidal chain to the acceptor site, so that this will be free, and again a newer T-acyl comes and a peptide molecule is attached with the previous peptide chain, so that the peptide chain continues growing. So ultimately tetracyclines, you can see this is the tetracycline. They binds to 30S ribosomal subunit, binds here tetracycline ribosomal subunit, and inhibits the amino acid tRNA at the acceptor site. So this is the amino acid tRNA. This is already, this peptide chain is present. The new tRNA is a new peptide, so that the peptide chain have to be elongated. So this elongation, so that a new peptide attached to the acceptor site is blocked by the tetracycline. Similarly, after tetracycline, we will read about the chloramphenicol. Chloramphenicol acts on the 50S ribosomal subunit. They interfere and transfer of the peptide chain from the P site, that is the peptide site, to the acceptor site. At this state, then this peptide chain which is present on the peptidal ring has to be transferred upon the new peptide already that is carried by the amino acid tRNA. So this transfer of the peptidal chain from this peptidal site to the acceptor site is blocked by the chloramphenicol. This is the another antibiotic, chloramphenicol. So this is, we will read about the this macrolide letter. Clindamycin ribosomal subunit, and they hinders the transfer, again back transfer of this peptidal chain from the acceptor site to the peptidal site. So this is already done, the steps are already done in the biochemistry. So you can revise this to see. So it is clear na. So amino acid tRNA have to carry the defined peptide chain, so that the peptide chain will elongate. So this is the step. At the first there are, you can see this. Now a new amino acid tRNA comes, they gives one peptide, and then from the peptidal chain, the protein chain that is already present, that is transferred from the peptidal site to the acceptor site. This one, this is transferred or happens. So ultimately you can, ultimately A1 to A4, so it has been elongated. Transferred back to the peptide, acceptor site will be open, and again a new amino acid tRNA comes, and a new peptide is attached in the acceptor site, and ultimately it continues, and ultimately a new happens. So blocks here and chloramphenicol blocks. What is the mechanism of action? So tetracycline mainly inhibits the protein synthesis mechanism of the bacteria. Which bacteria? Tetracycline is a broad spectrum antimicrobial agent, so it can inhibit any type of bacteria, both gram positive, gram negative, etc. are also blocked, and this blocking is done by the inhibition, and they are bacteriostatic. Tetracycline mainly attaches with the 30S ribosomal subunit, and ultimately they inhibits the amino acid to the acceptor site or A site. So T or amino acid tRNA attachment to the acceptor site, this is blocked by the tetracycline. And chloramphenicol is another broad spectrum antimicrobial agent. Chloramphenicol, and they transfer of the peptide chain from the peptidal site to the acceptor site by the chloramphenicol. So this is clear. And then there comes the clindamycin or other macrolides. They ultimately block back transfer of the already elongated chain to the previous peptidal site, so that the acceptor site will be open for the further attachment of the newer peptide bond. And the aminoglycosides we will read later. This mainly acts at the first step. So it is clear how the tetracycline acts, or how the chloramphenicol acts, or basically synthesis mechanism is blocked by different types of the other antibiotic agents. Again we will come this. So mechanism already we have seen. So two factors are responsible for the selective toxicity of the tetracyclines for the microbes. The carrier involved in active transport of tetracycline is absent in the host cells. That's why the adverse effects in our body is less. The protein synthesizing apparatus. So these are the similar type of the way by which our protein synthesis mechanism also happens in our cells. But other are less toxic or minimal toxic to our host cells because involved of active transport, because the drug have to be actively transported within the cells. This active transport is absent in our host cells, but this active transport mechanism is present in those bacteria. That's why it can enter within those bacteria but not enters within our cells, within our host cells. That's why they are selective toxic to the bacterial cells but not human cells. Similarly, the protein synthesizing apparatus of the host cell is less susceptible. So in spite of this, some amount of blood always enters in, but our protein synthesizing machinery are less susceptible to these different types of the drugs. Resistance is very common, develops slowly. Efflux pump is also developed. Plasmid mediated synthesis of the protection protein may arise. Tetracycline inactivating enzyme may also be synthesized. So these are the different ways by which a bacteria develops resistance to tetracycline or any other, in most commonly different types of the broad spectrum antibiotics. So there may be some plasmid mediated synthesis of some proteins that can protect this. Tetracycline inactivating enzymes can be synthesized that can inactivate the tetracycline. Tetracycline concentrating mechanism, that is that active transport mechanism, becomes less and develops slowly in graded manner. And cross resistance is always there. That is one type of tetracycline, it will be resistant to other types of the tetracycline also. Antimicrobial spectrum, already bacteriostatic drugs. Originally all types of the organisms except viruses and fungi, both gram-positive and gram-negative bacteria, rickettsial, chlamydia, plasma, mycetes, protozoa, all are susceptible. Cocci, all positive and negative cocci are susceptible. Streptopneumoniae, gonococci, meningitis are sensitive. Resistance develops to Staph aureus, Streptococcus pyogenes and Enterococcus. Diphtheria, anthracis, they are susceptible, not mycobacteria. For the Enterobacteria, it becomes not effective against the Pseudomonas, Klebsiella and Salmonella. So more or less you can see that they are susceptible to different types of the these bacteria, but in most of the cases some resistance have developed and that's why we cannot use this. There are some adverse effects, typical adverse effects of these tetracycline groups. Irritation. So mild nausea, diarrhea, esophageal ulcer can happen, colitis can happen. Another most common adverse effect of the broad spectrum antibiotic is the superinfection. This term you will encounter, that infection is always there, but we are using the antibiotics. On the top of this, another infection is gradually developing. This is superinfection. This happens due to disturbance at the first, that since they are broad spectrum, they are also killing our normal commensal bacteria also, good bacteria also. Infection happens. So for example, candidiasis, oral and vaginal, oral candidiasis or vaginal candidiasis may develop. Soreness and redness of the mouth, black hairy tongue, inflammatory lesions in the vulva, vagina, this can develop. Staphylococcus enteritis, hospitalized patients, in those patients there may be loss of appetite, abdominal discomfort, watery diarrhea because the commensals in the gut are weak. Pseudomembranous colitis, this is a very great situation of infection which is caused by the Clostridium difficile, that is characterized by the profuse diarrhea and fever. This is a rare but the dangerous adverse effects. So these are the different types of the superinfections. Superinfections can happen in most of the cases when we are using broad spectrum antibiotics for a long period of time. Difference of the, we can differ normal diarrhea with the superinfections of because these pustules or RBCs are absent in irritation type, that is normal diarrhea, usually the pustules or RBC are not there. But if this happens, if the profuse diarrhea happens due to the antibiotics. For example, you are taking some antibiotics, it is very common that diarrhea is happening. So whether this diarrhea is specifically due to infections or due to the superinfection, we can distinguish by testing the stool whether the presence of the pus or RBC is there or not. Liver damage, fatty infiltration, kidney damage may happen in those tetracyclines who are basically excreted from the kidney, except the doxycycline, because the doxycycline mainly phototoxicity is quite common with the tetracycline group of antibiotics, like skin rashes, mainly of the topical application. What happens? Some erythematous rash may develop, brown, black discoloration of the nails, loosening can happen. Doxycycline and demiclocycline, this phototoxicity is more. So you can be asked, there may be MCQ, that is, what type of the drug causes phototoxicity. So tetracycline group of drugs causes phototoxicity. Types of any other group of antibiotics, like brown discoloration of the teeth and bones can develop, because they ultimately forms a chelate complex known as the calcium tetracycline chelate, and this chelate can be deposited in the bones and teeth, and ultimately these problems develop. So when there is deciduous teeth, there may be some ill-formed teeth, ill-formed bones, and caries teeth can develop. At the crown of the permanent anterior dentition, in the tooth there is crown of the tooth that can be decayed. In pregnancy and childhood, if we are using this, there may be temporary suppression of the growth. So this tetracycline group of antibiotics should not be given in children, should not be given in pregnant mother, should not be given in nursing mother, that is, who are breastfeeding, because there is always chances of the bone problems and the teeth problems. Reduction in protein synthesis can happen, and diabetes insipidus can develop. Antidiuretic hormone and urine concentration. Tetracycline is the newest one. Basically, it is a glycyl cycline which are active against most bacteria that have developed resistance to the classical tetracyclines. So mainly these are active for acquired pneumonia. This is a very latest drug which can be used in serious infections, hospital admitted patients, hospital acquired pneumonia is there. Complicated skin structure infections, not diabetic food, it can be used here, but not infections due to the diabetes. Complicated here, but it is not recommended for hospital acquired or ventilator associated chest infections because of higher mortality it has been seen. It is also not suitable for urinary tract infections because only low concentrations are achieved in urine. So only this should be used in the treatment of the usage of the tetracyclines. Broadly, we can see that this can be used as a empirical therapy in mixed infections. What I am telling, that we cannot dictate that what type of bacteria is causing these infections at the first. We are not sure whether this is caused by the gram-positive or gram-negative. Then we have to add some broad spectrum antibiotics, and after that different diagnostic tests are done, and then if we are sure about which organism is causing this infection, for example some septicemia which is causing, whether it is gram-positive septicemia and gram-negative septicemia, accordingly we can narrow down the antibiotics. So firstly we can start as an empiric therapy, the broad spectrum antibiotics. This is the common methods of treatment of the infections. So first we don't know, so we can use the broad spectrum ones, and then if we know about the organism, then we have to narrow down these, because if the broad spectrum, ultimately there is always more chances of the resistance. That is the main problem. Rickettsial infections like Rocky Mountain spotted fever, all forms of the typhus fever, Q fever, we can treat this. Q fever is caused by the Coxiella burnetii. Atypical pneumonia, that can be caused by apart from this, it can be used in urinary tract infections, in MBBS, community acquired pneumonia, acne vulgaris, COPD. So we can discuss about this. Firstly, the tetracyclines remain useful as first line therapy for infections caused by chlamydia. This you should remember. So the common bacteria, gram positive, gram negative, newer antibiotics are there. If it is not responding this, we can use tetracyclines. But these are the atypical bacteria, like rickettsial infection, Brucella infection, mycoplasma infection, chlamydia infection. In those cases, usually doxycycline still now used as a first line therapy, doxycycline. So, mainly different types of the tetracycline use the doxycycline. So doxycycline now, doxycycline is very commonly used. For example, perhaps you can remember in COVID times, some of you have taken the doxycycline also, I don't know. Doxycycline is a newer tetracycline that have shown promise against the variety of the organisms. That's why it was used empirically during the COVID times. So it's a drug for many sexually transmitted disease, rickettsial infections, anemia, uncommon infections, pyrocystal infections, severe respiratory tract infections, we can use the doxycycline. Of the MRSA. MRSA means methicillin resistant staph aureus. That is, these staph aureus are resistant to normal penicillin group of antibiotics that are normally used for the gram-positive bacteria. You will read penicillins later. But when this becomes resistant, we can use the doxycycline. Doxycycline or minocycline or different other tetracyclines. The glycycyclines resistance and can be used for a number of infections due to gram-positive and gram-negative organism. Glycycycline is TG-cycline, already we have seen. So these newer ones, the advantage is, since for the many decades we are not using the tetracyclines because of the resistance. So now the newer tetracyclines now showing very good activity against the different types of the bacteria. But again, if we are using continuously, again the resistance can develop. Doxycycline has good activity against the streptopneumonia and Haemophilus influenzae. These two drugs are very notorious for developing community-acquired pneumonia, which causes substantial mortality in the wards. Excellent activity against atypical pathogens, mycoplasma and chlamydia pneumonia. So, mycoplasma pneumonia, chlamydial pneumonia, these can also cause pneumonia, fatal pneumonia. TG-cycline is effective as a single agent for adults hospitalized with community-acquired bacterial pneumonia. Already I have said. Time and again saying because these are very important. TG-cycline is approved for the treatment of complicated skin and surface infections. Already we have seen. Doxycycline and minocycline have good activity against staph and mainly useful for the MRSA infections. That methicillin resistant Staphylococcus aureus infections, cutaneous skin infections most commonly. Acne for 25 milligram orally twice a day, very effective in case of the acne. Resistance among Enterobacteriaceae and gram-negative anaerobes limits the utility of the tetracycline for intra-abdominal infections, because the intra-abdominal infections are mostly caused by different types of the gram-negative organisms like Enterobacteriaceae. So they become still now resistant to different types of the tetracyclines. Enterococcus, Tetracycline until now. A single dose azithromycin. You read about the azithromycin, which is a macrolide later, in the treatment of the uncomplicated genital infections due to the chlamydia trachomatis. So chlamydia trachomatis causes genital infections, different chlamydiasis, different types of the infections that can be safely treated by the doctor. Acute epididymitis, which is caused by the infection with the chlamydia trachomatis and Neisseria gonorrhoeae in men less than 25 years age. We can use the combination of can be added with other types of the antibiotics to treat the different types of the infection. Epididymitis means epididymis. There is infection in the epididymis of the testis. For doxycycline for 21 days is the first line therapy for the treatment of lymphogranuloma venereum. This is another sexually transmitted infection where we have to use doxycycline for a long period of time, approximately 21 days. Secondary or latent syphilis can be treated with a tetracycline regimen like doxycycline for 2 weeks. So syphilis, that is quite less in our as of now, but in spite of this there is syphilis that is caused by the Trichoderma pallidum, and the syphilis, if not it is treated, the primary syphilis can progress to secondary or tertiary syphilis. So we can treat this with the tetracycline group of antibiotics like doxycycline. They are life-saving, already we have seen they are life-saving in rickettsial infections like Rocky Mountain spotted fever, which is known as the epidemic typhus, murine typhus, typhus, Q fever that is caused by the Coxiella burnetii, rickettsial pox. You read about the organisms in the microbiology. It has been done, or it will be done. Okay. So clinical improvement, usually the clinical improvement in fact is dramatic because these are very atypical infections, rare in India but most common in the African countries. If we are using the doxycycline, usually within 24 hours clinical improvement is seen. Tetracycline in combination with rifampicin or streptomycin, you read chronic infections by the Brucella, Brucella bildensis, Brucella suis and Brucella abortus, brucellosis. This is another atypical infections. Mostly the Brucella infections is transmitted from some domestic animal to the humans. So this can also be treated by the doxycycline or other types of the tetracycline. So tetracycline group of antibiotics is very important as of now because previously tetracycline usage is limited, but now there is resurgence of the use of the tetracyclines, particularly the doxycycline, the premium one. Next, coming to the chloramphenicol. Chloramphenicol is which is obtained from a Streptomyces species, Streptomyces venezuelae, which is a natural moiety contains and now all the from this some synthetic moiety are developed, yellowish white crystalline solid, stable aqueous solution and nitrogen actions already seen. So they act by interfering with already peptide chain to the newly attached amino acid tRNA at the ribosomal mRNA complex. So basically they act on the fibers. So if you can remember this diagram, so the mechanism of action of all the antibiotics that acts on the protein synthesis mechanism will be easier. But if we start memorizing these lines like this, in every antibiotic there will be line like this, so it will be difficult. So you have to understand about by seeing the diagram so that it will be easy to dictate how the antibiotic acts, because it is very common any antibiotic of this protein synthesis mechanism will be asked about the mechanism. It will be not specific for tetracycline and chloramphenicol. You can be asked about the aminoglycoside, how it acts, or clindamycin or erythromycin. But if you remember about the protein synthesis mechanism and what areas did act, it will be clear. So it is clear. Already tetracycline acts here, chloramphenicol acts here. So differences with the tetracycline is they are highly effective in the Salmonella typhi. Until now we have not heard about the Salmonella typhi in the tetracycline. Salmonella typhi causes the typhoid fever, and in the previous in the 70s, 80s, 90s, in fact in first part of the 90s, chloramphenicol is the drug of choice for the Salmonella typhi, typhoid fever. But after that it becomes resistance, and now there are newer antibiotics are there by which we can safely treat the typhoid fever. So previously it is highly effective against Salmonella typhi, more effective against the Haemophilus influenza that also causes meningitis and influenza, Bordetella pertussis that causes the whooping cough, Neisseria meningitis that causes the meningitis. So less active against the gram-positive cough and spine in comparison to the tetracycline, Plasmodium, etc. So for the chlamydia, the drug of choice is the tetracycline group of antibiotics. Resistance develops more with the chloramphenicol. The indiscriminate use in the past in the developing countries. Previously, chloramphenicol is used indiscriminately. Resistance tends to develop plasmid. R means resistant plasmid. So these new plasmids are developed by the bacteria, and ultimately they are transferred from one bacteria to another bacteria, so all becomes resistant. So R plasmid mediated formation of transferases that inactivate the drug. So activates the drug. Acetyl chloramphenicol does not bind to ribosomes. So when this acetyl transferase comes, they causes the acetylation of this chloramphenicol, and this acetylated derivative ultimately will not bind to the protein synthesis pathway. So apart from this, there are some other mechanisms chances of the drug entering within the bacteria, lower affinity of the ribosomes to the chloramphenicol. Adverse effects. What are the adverse effects of the chloramphenicol? Chloramphenicol is there are some severe adverse effects. That's why it was also lesser used nowadays. For example, bone marrow depression, which is a notorious adverse effect that may cause aplastic anemia, cytosis and thrombocytopenia. So you know the bone marrow, all our blood corpuscles are developed. So when there will be bone marrow depression by means of this drug, there will be less of different blood corpuscles, so there will be anemia. Aplastic anemia may develop, there may be some agranulocytosis, thrombocytopenia may develop. There may be some non-dose that is present in your general pharmacology. So this does not depend upon the dosing of the drug. So in some individual with minute doses, this can develop, this adverse effect can develop. This is a rare one. Aplastic anemia is the most common manifestation. Aplastic anemia means RBC, WBC, platelets, none is ultimately developed from the bone marrow. So there is aplastic anemia, very severe, that can develop the idiosyncratic reactions, and there are some dose and duration of therapy-related myelosuppression is also there. That is, if we are using this chloramphenicol for a long period of the time, that also causes graded depression of the bone. So difference is clear now. With minute amount, with a small amount, that can be a very drastic aplastic anemia. That is the idiosyncratic reactions. Otherwise, if we are using this chloramphenicol for a long period of time, that also ultimately causes the bone marrow depression. So direct toxic effect is in the erythropoietic cells. So we can predict this. We know that if we are using this in high dose, if we are using this for a long period of time, ultimately bone marrow depression happens. But this idiosyncratic reaction we cannot predict. But this is usually not reversible, this is usually fatal. Nausea, vomiting, diarrhea, pain in injection, angioedema can develop. Another typical adverse effect of chloramphenicol is the gray baby syndrome. Gray baby syndrome can develop if we are using this in the infants, usually 2 to 9 days after of 100 milligram per kg, that is in the high dose, previously it was used. Within 24 hours, baby starts to vomit, and irregular respiration, abdominal distension will be there, periods of the cyanosis, loose green stool is there, baby turns ashen gray and becomes flaccid and hypothermic. Since there is cyanosis, so ultimately it looks like a grayish color, that's why gray baby syndrome. Also it does cirrhotic means there is already hepatic component. In those patients also there is grayish discoloration and ultimately abdominal distension, vomiting, all this can happen, but particularly this can happen in the babies. They in 40% of cases, see the mortality rate is quite high. This happens due to cardiovascular system collapse, due to inability to metabolize and excrete the chloramphenicol, because liver will be compromised here and that is needed for the metabolism of this chloramphenicol. So if you are asked about the chloramphenicol adverse effect, you have to write the most important: bone marrow depression, non-predictable, reversible. The predictable ones is reversible. It affects hypersensitivity and the Gray syndrome. Where it is used? Enteric fever, typhoid fever. Previously it was the first line of the drug. Meningitis, it can be used as a second line to third generation cephalosporins in the child and the adult patients. Meningococcal meningitis and Haemophilus influenzae, these two organisms are susceptible to chloramphenicol. Anaerobic infections like bacterial are susceptible to this. Intraocular infections like endophthalmitis. As of now, very commonly used in intraocular infections. There are chloramphenicol ointment is there, chloramphenicol drop is there. Second choice drug is the brucellosis infection, conjunctivitis, external ear infections, but these are very lesser used nowadays. Next, coming to antibiotics. Clindamycin. Already we have seen clindamycin acts at the last step of the protein synthesis mechanism. So they binds exclusively to the synthesis. Clindamycin is structurally similar to the macrolide antibiotics you will read later, but they act at the different sites. They inhibit most gram-positive cocci, including most species of the strep. Antibacterial diphtheria, nocardia that causes monocytes, actinomycetes, toxoplasma gondii, and has slow action on the plasmodia. So they have also different types of the effects on the wide organisms. Anaerobes like Bacterius fragilis. So remember, clindamycin now it is mainly used in case of the anaerobic infections. The previous ones all are mostly used in the aerobic infections. So they are mainly active against the anaerobic bacteria, anaerobes. Anaerobes, most common anaerobes is the Bacterius fragilis. Aerobic gram-negative bacilli, spirochetes, chlamydia, mycoplasma, and rickettsia. These are usually not affected by the clindamycin. So this is the mechanism of they blocks the so that the acceptor site will be free for the newer amino acid tRNA to bind. So ultimately clindamycin acts here also different sites, so we will read about this later. Side effects are there may be some rash, urticaria, abdominal pain. Major problem is again the superinfection, pseudomembranous colitis that is caused by the Clostridium difficile, and this is very common with the clindamycin. So clindamycin is associated with the superinfection, Clostridium difficile related pseudomembranous enterocolitis, it is known as, which is potentially. So now the use of the clindamycin is usually restricted to anaerobic and mixed infections, especially those involving the Bacterius fragilis, and this mainly causes some abdominal, pelvic and lung abscesses. So this oxygen. So the bacteria also cannot get the oxygen. So usually the anaerobes thrive within some abscess. So if there is some abscess or abscess cavity, so here we can use the clindamycin. So mainly this can happen abdominal abscess, very common abscess or lung abscess. Here we can use this. Aminoglycoside and cephalosporin we will read later. So usually there will be combination of the drugs. We can use the aminoglycoside plus clindamycin or cephalosporin plus clindamycin. In toxoplasmosis and with primaquine for pneumocystis jirovecii pneumonia. So pneumonia is again that is a superinfection. This mainly happens in case of the immunocompromised persons. Immunocompromised already due to some HIV/AIDS like that. Clindamycin have to be combined with pyrimethamine pharmacies and with primaquine for the pneumocystis jirovecii infection. And apart from the skin and soft tissue infections, and then prophylaxis of endocarditis in patients allergic to penicillin. So endocarditis means endocardium, there is infections in the endocardium of the heart. So endocarditis usually happens due to some streptococcus gram-positive organisms. So usually in case of the streptococcal throat infections, if we are not treating well, that streptococcus will remain there and ultimately they can be lost within the endocardium, and ultimately endocarditis and different valve disease can develop. Okay. So here the main treatment for the endocarditis is the penicillin, because this penicillin group of drugs are active against the gram-positive organisms. But there are many patients who are hypersensitive to penicillin, they are allergic to penicillin. So we cannot use the penicillin in those cases. So prophylaxis of this we can use clindamycin, and also in case of the skin and soft tissue infections. So this is all about the broad spectrum antibiotics. Thank you. Any questions? So within the broad spectrum antibiotics, very important is the doxycycline, that comes under the tetracycline group. So you have to read about the mechanism of actions of this tetracycline, chloramphenicol, clindamycin, where they are specifically used, why this is called broad spectrum, what is the indications of the tetracycline or indications of the doxycycline, very common questions. Next, most important is the adverse effects of the tetracycline, adverse effects of the chloramphenicol. Chloramphenicol, why it is not used nowadays, that bone marrow depression, that is very important. This have to be written, grave ABC in all this, and why mainly clindamycin is used, mainly in the anaerobic infections. So this is all about today.